Okay, so just to give a fair warning. So last time it was Commissioner Gerardo who had lost her voice. Today it's me. So like at some point I might not be able to talk. And hopefully Commissioner Chow can sit in for me then. Um, yeah, so other than that, let's start the meeting.
Okay, great. I will call roll. Commissioner Chung
Here.
and Commissioner Chow.
Present.
I'll note that Commissioner Guillermo is here, but because she's not on camera, she won't be able to vote. So I'll just note she's here, but she won't be an active member on the minutes, except for her comments. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. And I also just want to acknowledge that this is November is American Indian and Native Alaskan Heritage Month. Commissioner Green will make some comments at the full commission meeting about the holiday. Commissioner Chung, since your voice isn't so strong, I'll call the items for you. Would that be helpful? Great. Item 2 is the approval of the October 4th, 2022 minutes.
I move approval.
I second.
Okay, great. And I don't see any public on the public comment line. Let me just say also, Tracy, if you can log off and on, I see you, but I'm not able to move you over to the full to a full panelist. So if you log off, I can probably get you back on. Thank you. So commissioners, with no public comment, I'll take your motions as action for approval of the minutes, and we can move on to item 3, the monthly contracts report. Mr. Goodwin.
Good afternoon, commissioners. Hope everyone is doing well. Just wanted to begin with, as of this month, a brief statement appears in the last line or row of each contract in the Health Commission report to briefly state the results of program performance, summarized from the most recent monitoring report, with the full performance backup document currently being provided as a backup document for the commissioner's reference. Please note that the UCSF Infant Parent Program, or IPP program, should have been pulled from this report, as this program will now appear instead in next month's Health Commission report and will be brought back for discussion at that time. We have a total of 6 items for you today. From this month's Health Commission report, there are 4 items. First up, we have the Richmond Area Multi-Services Incorporated, or RAMS, peer-to-peer services. Today, we are requesting a contract amendment with RAMS for their contract that we reference in shorthand as the peer-to-peer services, in order to increase the total contract amount with contingency to an amount of $29,116,181 to extend the contract end date from 9/30/22 to 6/30/26, or an additional 3 years, 9 months. This is the first amendment of this contract, which was a new contract on 7/1/21 following the solicitation of RFQ 27-2020, which covered the peer-to-peer services, including the certificate program. These are the services that will continue through 6/30/26. In the prior contract, there were services that were finishing their solicitation authority term. So these services were added to this contract to complete their duration. For example, the whole person integrated care will be solicited out and is not included in this contract after 12/31/22. The department is requesting approval of a contract amount with contingency of $29,116,181, which is an increase of $19,116,381, and as stated, to extend 3 years and 9 months. The annual amount without contingency will increase by a rate of $17,512, which represents a reduction of the WIPC program on 12/31/22, a reduction of about $187,000, offset by increases in fiscal year 22-23 to reflect a 4% CODB and enhanced outpatient support. The proposed amended agreement is authorized under RFP 27-2021. I wanted to clarify, based on a question we'd received regarding listed services in the Health Commission report, that the service modality ICM FSP OP is an acronym for Intensive Case Management Full Service Partnership Outpatient Services. I apologize for the appearance of any acronyms in this and past reports. And I will steadfastly clarify each of these moving forward and remove them from future reports. If commissioners have any questions, Tracy Helton, DPH MHSA Program Manager and Acting Deputy Director of JEDI, which is Justice, Equity, Diversity, and Inclusion, is here to respond.
Commissioners, any questions or comments? I see none from Commissioner Chong. Commissioner,
Thank you.
Commissioner Chow, anything from you?
No, he clarified ICM, which I initially thought was some sort of missile, so thank you.
No worries.
Yes.
No worries. I'll keep a sharper eye out for those moving forward.
Oh, no, it's fine. It's just that when there are unusual, acronyms, then it'd be nice to perhaps put that first, and then your future can easily reference it, and then it'll be up to us to remember what it is. So, but very extensive, and certainly looks like it's good work. So I have no other questions on it either.
Great. And commissioners, I should have noted this to you all before the meeting, but I met with Ms. Ruggles and Mr. Goodwin because Mr. Goodwin is new, just to help him with the learning curve and what your expectations are. So we're, as we all learn together, we'll refine this, and make hopefully your committee experience as smooth as possible. But it sounds like we can go to the next contracting.
Okay, next up, we have the Health Management Associates Incorporated. In May of 2022, DPH entered into an emergency agreement with Health Management Associates Incorporated, or HMA, to conduct an operational, clinical, and organizational assessment of Laguna Honda to perform recertification survey readiness assessments and a mock CMS audit surveys for an amount not to exceed $3,782,365 from May 9th, 2022 to June 30th, 2023. The original agreement was approved by the Health Commission in June of 2022. The proposed First Amendment will increase the billable hours from 8,727 to 14,540 and adds funding for travel expenses for the vendor to support recertification. The additional hours will address recent updates in Phase 3 CMS regulations, which went live on October 24th, 2022. This contract is subject to approval by the Board of Supervisors. The funding has increased in order to engage additional resources for this amendment. The additional resources reflect 5,285 hours of highly specialized consulting services in the subject hour in a very short period of time. The department is requesting approval of a total contract amount with contingency in the amount of $6,236,277, which, as stated, is an increase of $2,453,912, with no extension to the term of this contract. If commissioners have any questions, Baljit Sangha, Laguna Honda Hospital CMS recertification co-incident commander and Chief Operating Officer and Deputy Director of the San Francisco Health Network, is available. Thank you.
Commissioners, any comments or questions? Baljit rolls off the tongue.
No, I guess my only question, well, not the only question, but this seems to only say that it's for addressing Phase 3, but it would sound like we've got a greater commitment, including a continuation of a recertification program. So does this not extend beyond, or is it only for Phase 3? And then are we going to expect an additional contract for the additional period of time that it might take in order to do recertification? Or is it that Phase 3 is one of the unique things to be addressed, but that these contract hours will be continued to be used as they are now for all of the continued work that is now being extended somewhat.
Thank you, Commissioner. And also, I'd be remiss not to say thank you very much, Dean, for that summary and helping us get prepared to present today. Commissioner Chow, the latter statement that you indicated is accurate. Phase 3 is one component of the evolving scenario as we pursued recertification, which is not what we were aware of when we first initially launched these contracts. As you know, the Laguna Honda is not getting grandfathered into any policies, procedures, or regulations, and that became very clear over the last couple of months, but which were the months that were post when this contract originally came before you all. But you're absolutely correct that phase 3 that went live on October 24th, just a few short days ago, is a significant component of what is part of the additional hours to that are being extended here.
And so you've then clarified that, and this will be used to try to modify our current regulations that address the issue of substance abuse that will then meet the new phase 3 requirements. Is that also part of the scope of this?
Correct. The HMA subject matter expertise, and again, the HMA itself specializes in publicly funded healthcare and human services policy, and the programs and financing and evaluation. So their expertise is certainly being utilized to ensure that the Laguna Honda policies and procedures, which I know that some of you have heard about at JCC, are keeping up to speed, are also evolved, and are also aligned with the policies and procedures that a SNF facility is expected to have in place as of October 24th. In addition to then having the written policy in place, then there's certainly the additional component of work to ensure our processes follow suit and are actually aligned. And that's where HMA is coming in to support that work along with the additional resources we have in place.
Okay, I have no other questions, and certainly this is going to be needed for us to be able to address the new regulations plus the continued work that's needed for the recertification. Thank you.
Yeah, thank you. And I think that like even when this contract's over, there's going to be more discussions around like how to create an ongoing process to hold ourselves accountable. So looking forward to those conversations as well.
Thank you, Commissioner Chung.
Thank you very much. Dean, let's move forward.
Okay, item 3 is UCSF Citywide. This is a program that follows a single point of responsibility model, or an SPR, which is known as an intensive case management program. We have a contract amendment with UCSF Citywide to increase the total contract amount with contingency to an amount of $114,039,919, and to extend the contract end date from 12/31/2023 to 12/31/2027, or extend the contract by 4 years. The Health Commission previously approved the subject contract in December of 2018. The amendment is authorized under the solicitation RFP 11-2017. The department is requesting the approval of a total amended contract amount with contingency of $114,039,919, an increase of $53,215,506 to extend for 4 years. Essentially, the same funding is being repeated each year. While I've included a lot of detail in the annual contingency in the breakdown, really the main change is simply the addition, $444,341, and can be broken down by 404,011 for the CODB, and MHSA provided a 3% increase of 34,508, which adds up to the 444,341. The rest of the information is in your handout there. If commissioners have any questions, Elise Miller, Program Manager of Adult and Older Adult Systems of Care of the BHS within DPH, is here to respond. Thank you.
Commissioners.
I could just ask for clarification. Under the units of service, it's being billed under a capitated rate rather than each of the staff minutes and so forth. Is that correct, or is that an estimated capitation, or what?
That's a correct amount. So they have find out of patients or clients that they see per year.
I'm sorry, could you turn off your camera? Your voice, your audio's off, and if you turn off your camera, maybe you'll have more bandwidth but we're not able to hear you well. Could you repeat that, please?
Yes. Oh, hold on. Sorry. How is my audio now? Is that better?
Sounds fantastic. And please say your name and your title so the commissioners know who you are. That's great.
Good afternoon, commissioners. My name's Elise Miller, and I'm with AOA System of Care, and I'm the program manager for the UC contract. And so to answer your question, it is a set number of clients that they see per year.
Okay, no, thank you. So they have this as a maximum of a year, and then you've worked out that that is, so they receive a capitation rate for each of the clients.
Correct.
Okay, thank you. I have no other questions.
Great. And looks like Commissioner Chung doesn't have questions.
Well, I have to like let people know that I'm pretty familiar with like all these programs, in my private prior experiences. And so yeah, so I tend to have fewer questions around that. This is a great program. Both like the community focus and the forensic case management's been around for a long time and have really helped folks to stay away from more advanced care. Yeah, or or in some cases prevent them from getting incarcerated again.
Absolutely. Thank you so much for your kind words. I know that I'm going to relay what's said in this meeting, but I think all of the sort of support that commissioners are giving today is like absolutely needed and appreciated. So thank you so much.
And thank you for the work.
Great, thank you.
Thanks. And let's move on to, I think, the last contract on the reports.
Felton Institute, Felton Street Case Management. Fourth and last item in the Health Commission report is approval of a contract amendment with Felton Institute for the Felton Street Case Management and Behavioral Health Engagement Specialist, which is both an existing team and a team that has been providing support to the Felton Street Case Management Behavioral Health Engagement Specialist to increase the total contract amount with contingency to an amount of $9,960,904, and to extend the contract end date from 12/31/22 to 12/31/23 for 1 year. The Health Commission previously approved the subject contract in January of 2021. The amendment is authorized under a 2142 sole source waiver. The department anticipates soliciting these services in fiscal year 22-23. So this contract will not be extended following that solicitation. The department is requesting the approval of a contract amount with contingency of $9,960,904, and the annual amount without contingency is an increase of a net of $287,436 due to an increase in funding for behavioral health engagement specialists to support efforts in the Tenderloin, along with the 4% cost of doing business increase, offset by the STAR grant ending, STAR STARR supporting treatment and reducing recidivism, or a reduction of that of about $621,353. If commissioners have any questions, Robin Kendler, Acting Director of the Street-Based and Justice Involved Behavioral Health Services with DPH, is here to respond.
So I read the monitoring report and the backup detail, and I'm wondering what you're actually intending to do, because it just seems to be information that was provided to us is that somehow management of the programs are not actually, seeming to be able to produce for you what we would expect in terms of their reporting back to us the work they're doing. At one of your programs, I mean, there seems to be some not only missing the targets, but also being able to, I guess, achieve some of your performance objectives, perhaps within those who are even within the target. So I know what your words are saying, proposed training, but is there anything specifically that you found that is going to change performance? Because if I remember, we've had similar problems with the Family Service Agency. And I could be wrong about my memory, but
Hi, I'm Robin Candler, acting director of the Street-Based Injustice Involved Behavioral Health Services, and I oversee these programs. And I think some of the issue is a reporting problem. And for example, like it says that there's the units of service is 0, but that I've talked to the business office and it's just a matter of moving programs to cost reimbursement during the COVID time, and that there's no place for asking for the units of service, and so that didn't get reported. But also, it's a matter of like they had a new program director who was getting up to speed on the reporting systems, and I actually think that our teams were working and meeting with their teams very regularly and talking about clients and talking about the outreach that they're doing and about the outcomes. And I have no doubt that the work is being done and effective, important work is being done. I think that they have to work on reporting and showing the work and showing the effectiveness of the work.
well, I appreciate your perspective and the fact that you seem to feel, because it is important work that they're doing, that this is more documentation reporting, and you're going to all be working on that. But I really do appreciate that insight that we're able to get.
I actually think that it's a little bit more than just, like documentation reporting, because it's client satisfaction survey, that they're not able to um, complete, and I think that that's a really important thing to point out, like especially for programs and services that we we what's the word? What's looking for? We pay for. So
We
you know,
expect it.
yes, to expect it, because it's about health equity, and we want to make sure that patient experience is as well. So yeah, so I think that it's interesting to see that they have like performed 50% of the contractual work, and and they don't have a complete client satisfaction surveys, and but I'm glad to hear that like you are providing some assistance to them so that they can get back on track.
Yeah, and I appreciate that. And I would say, a lot of this reporting that we're talking about right now was during the heart of COVID. And so clearly there were some struggles there. But the client satisfaction, I agree, is very important. And we'll definitely make sure that that's happening now.
Yeah, I have a question to follow up on Commissioner Chung's
Yes.
question. Is the client satisfaction survey, is that a standard instrument across all of the service providers that we contract with?
Hi, commissioners, this is Michelle Ruggles. It is not a standard that across behavioral health, there is a standard because Medi-Cal requires certain questions to be asked. But if you fall outside of that, there is a requirement that everyone has a standard, that everyone has a client satisfaction survey. So there's some variation, but their standard is that you obtain client satisfaction. Behavioral health happens to have a tool that's set for them by the state.
I think it might be helpful in light of Commissioner Chung's question, if we could be provided samples of the surveys, because it's one thing to ask whether they're being done or not being done and why, but it could be the instrument itself is, problematic one for the clients to respond to or to administer. And I think it just in terms of our oversight of program, it might be helpful to understand why then the return rate might be lower than expected if the instrument or the administration of the instrument is one of the reasons, as opposed to, they just, it's just not something that people prioritize.
Thank you, Commissioner Guillermo. And commissioners, I just want to throw a thought your way. If you choose to approve the whole contract report, including this contract, you could ask for, let's say, a 6-month follow-up where you all just get a follow-up on this vendor's performance so that your oversight isn't just waiting for another modification, but you're checking in because you're obviously concerned. You voiced concern in many ways, although the responses from staff seem to show that it could be COVID time related. So just want to throw that out there to you that you all could ask for that along with your approval process. Any other questions or comments from you, commissioners?
No, I just wanted to say that, yeah. So we can say that everything is COVID related for the last 3 years. But now that we're moving forward, I think that we really need to like be a little bit more vigilant around, the monitoring side of things. But thank you.
All right. Well, I think we're at the end of the report. And so unless commissioners, you have other comments, there's no one on the public comment line. So this is a time to consider approval, please. And any other requests for updates or, future items on the agenda related to these reports, the vendors.
So I would move for approval of these 3 contracts with the caveat that we have Felton return as a contract, because I think I still remember in the background that family services sometimes can be problematic, and we like them to be successful. And also that as a direction to our executive secretary to see that the members of the commission are able to see at least the behavioral health client satisfaction, which seems to be a uniform document.
Sure. Yes, sir. All right. That's a motion. Thank you. You have a
So
second?
can we make sure that we have the right motion? So it is to like add this to the consent calendar for
Oh, sure.
commission approval?
Absolutely. That's what I was needing to do. Recommendation to the commission on the consent calendar.
And then, Mr. Chung, you're the only voting member in the meeting today because the commissioner.
Yes, and yeah, and so of course I second.
Great, thank you very much. So the item is approved with the 2 motions. And thank you all those DPH staff who presented, and we can move on to item 5, a request for approval of a new contract with Special Service for Groups, OTTP. Ms. Lusbader, I think, will present. Although I don't see her here. Oh, yes, I do. There we go. Allison.
Hi.
Please go.
Okay. Yeah. Hi. So I believe that the commission got notice that in the summer, we had to move our SOAR contract that we have with the school district from one program, which was Oaks Children's Center, over to Special Services for Groups. The reason for that was that the Oaks Children's Center program unfortunately had to close due to some financial difficulties. And as part of the original RFP process, Special Services for Groups was the next contender in line. And we were really pleased about that since we have a long partnership with them that has been really successful, as does SFUSD. So in light of that, we were able to transition the program over to Special Services for Groups. They were able to take all of the students and clients that were previously at Oaks. It was a fairly smooth transition because all of the staff, not all of the staff, I apologize, 5 out of the 8 staff, I believe, of Oaks also was able to transition over to Special Services for Groups. So that was completed in time for the new school year by the end of August, and they have now been functioning for the last couple of months, and so far so good. It's been going fairly well with little disruption. So this is a new contract for Special Services for Groups.
Thank you. Commissioners, any questions or comments?
No
I
question
think,
from me.
Yeah, it seemed to me that the reason for retroactive, I guess, is because you all had to move quickly.
Mm-hmm.
It might be that I'm not sure, maybe that's a discussion we'll be having anyway, Mr. Wagner, in terms of finances and whatnot, in terms of how to be alerted earlier. But understand that, therefore, then you were able to move these people in July 1st, is that correct?
Yes, yes, July was our transition month, because July was a transition month where we still had a contract with Oaks, and they were working to transition the clients over. We wanted to have a month so that we could pay the current therapists that were at Oaks, so that we could ensure that it was a smooth transition as opposed to just abruptly cut it. So we kept it open. We had an overlap there in July, and then they took it on fully by August.
Okay.
And actually now I have a question. So when some of the staff from Oaks transition over to special services, are they therapists that we're talking about? Because I think that if
Yes.
they are, it's great, like, so it's always nice to see familiar faces, and rather than, like somebody that they don't know at all.
Right. We were really happy that they were able to absorb most of the staff. Yeah.
So I have no further questions.
Do we have a motion?
I would move the recommendation of this contract to the consent calendar of the Health Commission.
In a second.
Thank you. And with those two actions, the number 5 is approved. I realize I skipped number 4, so let's go back. I apologize, Ms. Ruggles. Item 4 is revisions to the summary of contract requests to the Health Commission template.
Hi, Michelle Ruggles. We can do that now, or if we can finish the last contract.
Would you prefer, does it matter to you, Ms. Ruggles?
Doesn't matter to me, just for the, okay.
I'll just-
Yeah, hello, commissioners. First of all, I sent this memo to the health commissioners, and I was writing it from home. I'm like, I need to make sure I spell Commissioner Chung correctly and make sure nothing changed since I haven't been to the Health Commission, which is why your name is blank. So I made it worse. I could have misspelled it. It might have been better than a blank. But anyway, so I sent you a memo, and in this memo, hopefully it was clear, but I wasn't at the last meeting, but I understood from reading the comments and talking to Dean Goodwin that you pointed out some of the form's deficits. And earlier, a couple years ago, maybe, the Health Commission was really helpful in revamping the monthly contracts report layout. And this template simply hasn't been touched, but you really pointed out some obvious questions like, why is there a variance if it's brand new? So there shouldn't be any. So what we did was, based on those comments, decided it's time. So we circled back with a bunch of staff, contracts office staff, and also staff from the Health Network, Zuckerberg, et cetera, to just get a better understanding of what some of these terms meant. And so what we have proposed for you is the major change would be that we have 2 templates. One template that would be for new contracts that are community-based organizations, and the other template would be for department operational support, which is a term we're trying to start using, DOS, instead of for-profit. And also that would be our program administration contracts. So that's the biggest change, and really that's because the language isn't quite the same. What we're presenting to measure isn't quite the same. In a private for-profit, you'll have a CEO versus an executive director. So that's why we have the 2 forms. Sorry, they probably are longer in the attachment in the memo than they will be in person, just because I left the prompts in there so you could see what we were thinking as we were writing them. But so that's the biggest change. Then we got rid of variant, so it's just trying to look more simple and streamlined. One of the questions that's come up while I was before you is how many years has this vendor been doing business with DPH, which sometimes has been answered as 0 because this is a new contract. But then it's been like, but you've had other contracts. So we've simplified that, or maybe clarified that by asking, do you have any other agreements with this vendor? And if yes, how many years has DPH contracted with this vendor? I might insert the word approximately because I've realized it's not that obvious to find out if it's someone that's been like 20 years, which year exactly. But so we have that. And then the other part that was actually helpful, I thought, for us, because I reached out to the Office of Health Equity, and so they have come to you before, Dr. Bennett, and presented their health, I'm going to mix up the acronym, Health Impact Equity Assessment, and which is a tool to look at equity across our programming that the Office of Health Equity is working on now to do an implementation plan. So in this report, we added a section, and this is really focused right now on the CBO template, which has primary target population. So we're looking at the neighborhood and then who's the target group within that. And so this will be helpful to them because, and we've added them to the CC because they'll be flagged when there's updates. And eventually we will have a contract system where we can keep this data. But in any case, this is a flag for them. And then on the, where I think it said, I'm not looking at the old form, but like cultural competency planning, it says health equity and inclusion compliance. And so this may change slightly, but it's a statement, it's a generic statement, but as we implement, as the Office of Health Equity is able to implement the new assessment tool, then that information will go into this section. So you'll be able to learn both in the monthly contracts report and these individual templates, how this vendor fits into the department and the city's efforts towards equity and inclusion. So that was the other change. And then otherwise, I'm open to any questions, but I think it's fairly straightforward, what we tried to clarify, and open to any recommendations or changes or questions. And then we can finalize at that point. I did use the special services for groups contract today on that template, so you could have an example with the real template, which I found actually helpful. I think it works better, but and then the next contract that you'll hear today, I think it's the last new contract, is for SisterWeb, which is using Haluna Health as their fiscal sponsor. And so in the future, that contract would go onto the new form, but it's right now in the old format. I'm just bringing that up based on a question that we received. But I think if you look at the new form, and if you still have it in front of you, the special services for groups, you can see the box that says proposed units of service. And so it's pretty clearly, hopefully, identifies the unduplicated client or duplicated client. And like it just calls out some of these data that was really buried in the old format, because the old format was really speaking much more to for-profit, if you will. It had like quantity, unit price, amount. So we always had to tailor the contract that was using the form. So now we just have the two formats.
Commissioners, any questions or comments? Thanks, Ms. Ruggles.
Yes, it's just well, kind of like one questions with two parts. So I noticed that, in this new template, like you have the for program administrations contracts only, and, and it's the line that lists, total indirect expenses. Um, I don't think that I've heard us talking about indirect expenses too often. And so now I have a questions, is there a cap on the indirect expenses, or what's the formula for it?
Yeah, that question. So yes, to answer the question, the indirect does have a cap of 12%. And it might be 15%, and I'm totally blanking, but there is a cap. I think it's 15%. That question though that you raised and identified is the program administration contracts have also been called fiscal intermediary in the past, but we've sort of changed the role of the program administration contract. So often that's a vendor like Haluna Health or Public Health Foundation. And so that particular question, and maybe it needs to be reworded, is asking how much money is the program administrator getting to do this function? Like how much of the total funding goes to them versus direct treatment? And so in our regular, or if our like CBO type of contracts, there's a standard indirect and it's paid to the vendor. And so it's not really ever been pulled out as a separate, as something separate because it's all part of the vendor's operations. It's really was specifically for program administration.
So
I'm
that makes sense.
wondering if we've called it something else though, and that's why but it's really like the fee. Sometimes it's a flat percent, but that's where it came from.
Yeah, maybe just call it fiscally sponsored projects or something that's a little bit easier to recognize.
As opposed to program administration?
Well, program administrations can be a lot of different things. So it could be just the organizations itself with, administering different programs, and their operation expense becomes indirect, right? And so it was a little bit confusing for me.
Yeah. Okay, I'll think about that. And then this will be confusing too, because the next contract, so we hire program administration contracts. For example, you've seen lots of them during COVID, like where we had a COVID contract that hired, we had a program administrator that hired many community-based organizations that were very small to reach the community. But the program administrator pays all the invoices, does the reporting, does the bidding process. So it's a fairly robust role, which when we have a program administration contract, we would be describing what it is that they're doing. The next contract is a little bit different, even though it will look the same. And that is that SisterWeb, you'll find this out, was the vendor that was selected to provide the services, but they're using Haluna Health as their own fiscal sponsor. So sort of ignore program administrator for a second when you see that next one. But I'll think about that and see how to present it in the template. I think if it's an actual program administration in the template, it'll be clear. But let me come back to you with a suggestion maybe on that.
And Ms. Ruggles, I'm thinking about the Public Health Foundation, that kind of fiscal sponsorship where all they do is it's a pass-through, which is, I think Commissioner Chung saying is very different than a program that's going to administer a program in any other way besides like money passing through. And so the two are different.
It's not really money passing through. They like Public Health Foundation gets selected. I don't mean the Hearts one, I mean like the penny, right?
Yeah.
So the Public Health Foundation gets selected through a solicitation process. And so in that role, they have multiple functions that they get paid to do. Like they also go out to bid to select the community-based providers that are really too small to enter into contracts from the department. So and then they're paying all the invoices and they're keeping track of the evaluation. They might be doing, so they actually have a big role and they get paid an amount of money to do that. And in the past, we've always included that as, we haven't really called it out, but when we have showed it on the monthly contracts report, we've always identified the amount paid to them for doing that function versus the amount for the treatment. And so I think it's like, because it's been pulled out here, it's seeming like it's something different. Then maybe it's not different than it has been in the past.
I didn't mean to convolute to make the conversation.
No, it's confusing because it's all the same words used in different ways.
Commissioners, any other comments from you? And Commissioner Guillermo, any comments from you or questions from you on this?
Yeah, I apologize. I don't have a good use of my vision right now, so I'm not sure what to refer to. But I have two questions. One is where would we have the discussion about an appropriate amount that the contracts provide for overhead or program administration? That's one question. And then the other is quite different. It's around, I think on the contract, on the new contract form, contract request, is there a place, I think I recall seeing that there is now KPIs that are supposed to be listed, and I don't recall seeing that on the example of the special services for groups.
Yeah, the special services for groups is on the other template, but so these are new contracts, so they probably won't have had any type of monitoring in the past. So that comment or that section is just to say where they're going to get monitored. The program monitoring will happen with on the nonprofit side with the Business Office of Contract Compliance. And then on the hospital, if you will, department operation support, there's a number of places where services are monitored to make sure that the contract is meeting its goals.
Okay, just generally looking for an opportunity for those specific contract monitoring objectives or requirements are going to be provided ahead of the contract approval.
Commissioner, you mean future approval? Because this is your first approval. You mean if
Right,
right. Okay.
right.
Ms.
So it's just, I guess this is still a work in progress, or it constantly improving. But it is something that, just in terms of the role that we have to monitor and provide some oversight, I think information that helps us match what the performance indicators are as a contract is being executed and matching that to what was being requested or described in the contract or the proposal. So I'm just not sure where those are going to be provided to us.
It hasn't been in the past provided to you for a new contract, but well, I've been involved with that. I don't know about the other health commission subcommittee meetings, but I've been involved in doing presentations about monitoring objectives and how they get it developed and what's used. It's more generic in behavioral health, for example. Well, it's a longer discussion, but in behavioral health, if it's outpatient, it's going to have these objectives. So they're mostly standardized objectives, but it sounds like what you're interested in knowing though is when there's a new contract that hasn't started yet, what it will be monitored on or what objective, is that right?
Yes.
Okay.
Yes.
And Commissioner Guillermo, it also sounds like I'm intuiting with this, but that possibly it might make sense to schedule a refresher on contract objectives and monitoring next year, since it's been a while since the committee's heard that, and you all can then dive into some of these like ancillary discussions. Would that be helpful?
Yes, that would be great. Thank
Okay.
you.
Thank you.
And then the question about the overhead.
Oh, so I can speak to the CBO contracts that I know much better, but the overhead is, or we call it indirect, is a set percentage. And why I'm blanking, I don't know if Dean is still on here, but I think it's 15% is the very maximum. And that's been set by the Health Commission for years. And there is actually a lot of discussion going on at the controller's level about this, with this whole subcommittee working on this, because there is a cap. And there's many contractors that feel that the cap is far too low. But there's a cap and it's pretty consistent across other city departments. And so with the program administration contracts, I think it's the same. It's usually less than 15%, and then we'll state it. It's not above, and it's usually less.
Yeah,
And
so I just feel like in light of I'm aware that there is a larger discussion about providing sufficient funds uh, uh, to any, particularly nonprofit contractors, service providers in particular, that is going on. And I just would appreciate, I think either this committee or the full commission having an opportunity to have that discussion or be part of that discussion as well, as it relates to the Department of Health contract.
Yeah, I had some comments on this, and as Michelle says, this is a work in progress, of course, and being able to see a sample was very helpful. I guess the first question I had was in regards to what you separated out is sort of departmental operational support and then a CBO. But what happens if we have a profit company that's actually going to be delivering services?
well, we've called it community-based organizations. So if we had a service provider that fit that model, or that just the way we commonly think of that, like BART, the methadone provider, it would go on the community-based
So
template.
maybe wouldn't you like to retitle that to be sort of like direct services or something as versus support services? I mean, so that and then I do think, I mean, we've got room there to put down it's a profit or nonprofit.
Yeah, so we're not, I apologize for using that shorthand. If you look at the top of the template for the community-based organization, it says a CBO contract is an agreement for the provision of direct treatment / services that serve as an extension of DPH service delivery system. So that's what would be in this template.
All right, but my only concern is if we have a profit company that's delivering services for direct services for us, that this kind of presumes that everyone who delivers additional direct services are CBOs. So I think you should think about whether or not we want to change the terminology of that, and then continue to mark whether it is a profit or nonprofit company, because I think your proposal of separating the two out because they have certain different parameters is very helpful. but I think to limit your form to only CBOs,
Do
unless
you do
only
you-
contract with CBOs.
but I guess I was thinking of CBO as the type of service in the community, but if that automatically means to you nonprofit, I
Yes,
wasn't
it does.
thinking, so
Yeah.
it does to you. Okay.
Well, at least the implication is that it's nonprofit.
And I think that's a sort of a popularized notion across, the field and the industry, that if you're a CBO, that you are sort of equates to nonprofit.
And that's why it looks like you want to eliminate the term profit or nonprofit.
Yeah, so these acronyms, like it's kind of confusing to start, like CBO, ASO, NGOs, and they can all be referring to the same organization. So I think that having some kind of like better descriptions would help us understand the nature of it. So I think that that's what we're getting to. Like, yeah.
Right. Yeah. And
Open to suggestions. It gets super confusing because you have PhD, population health division, prevention, so it's not direct treatment, but I'll figure out something. We have about 3 for-profits delivering direct treatment, but so I'm open to what you would replace that term with.
And
I think that
Commissioner
there's
Dean
a-
struggled. I'm confirming that Dean checked, and it is the 15% cap on indirect. 15%.
Okay.
Thanks, Dean.
yeah, I think that's a different discussion because the question is indirect versus direct services and how much. Seems to me that CBO's discussion have been also that our direct services are not being compensated appropriately because the 3% or what we're giving as the cost of living is not keeping up with their own workers who are delivering direct care. I hate to see that we're going to build out huge offices for sort of like what some United Ways had done in the past, and make the indirect very very nice and still not pay the direct providers. So hopefully that's a type of discussion I think Commissioner Guillermo is probably interested in too. There were 1 or 2 other questions that I had. I did think overall that on your sample, it was really, to me, it was very helpful, but that I think that there is a little repetition where we could shorten back the initial summary to what you did have because you have an excellent purpose of the contract, which is really very helpful to understand what is happening, and your proposed units are much clearer. I think the only other issue, which I would kind of leave up to other commissioners, is I did find in the past it was useful to know that the first year included quite a sum for startup, for example, or it was a startup, and then the regular, say it's a 5-year contract, contracts then are down to let's say the first year was $1 million because 500,000 has to go into building out the floor, and then the other 4 years or a $500,000 contract. That kind of helps us if you're otherwise saying they're all 750,000 for each of the 5 years. It's a little misleading in terms of the total cost, and you could then actually, unfortunately, misunderstand exactly how much it was going to cost. And then if you multiply out the unit cost, it actually wouldn't come out right. So maybe it's a difference of your first year startup versus normal, which is what you're carrying now. But I think that that's a helpful discussion within the new contract as to whether or not there is some first year costs.
Okay, we actually included that in the department operational support template. It has one-time upfront costs, but we can repeat that. It happens more on that side than the other contracts template that shall be named.
Sure.
that we don't have it's not more of the cases, it's probably like a smaller year, but okay, so something to differentiate if the first year, for example, and the second year are different.
Yeah, I think so that we, and especially if we're going to multiply out units, just to check the math and whatnot and get a feeling of where it is, it won't actually come out.
Okay.
Otherwise, I think it's worth, trying the format and, like I said, do a little shortening of the initial summary because you already have a very nice section on purpose that's very helpful. And the section about the target populations, I think, is very helpful.
Okay.
Any other comments, commissioners? I'm a little also concerned about time. I'm wondering, does it make sense to come back and have a check-in on this in 6 months or 4 months or something, so that after you all tried it out, or is this the discussion, Michelle? This is towards you too. Is this like a one-time discussion, then we move forward?
I would hope you could try it out and it's sort of it's sort of a work in progress for a little while, not 6 months, but uh, when you feel comfortable, and I'd leave it up to our other commissioners, but just to try the format and continue to do it like you did for the first sample, I think allows us to refine small, tweaks in it, sort of like we did with the amendments, so that we could then fine tune it. I think if we were locked in for 6 months, you kind of lose an opportunity to be dynamic and make the changes a lot sooner.
Okay.
Any other questions or comments, commissioners, before we move on? All right, thank you, Ms. Ruggles. Let's move on to item 6, a request for approval of a new contract with Haluna Health to provide, actually, Haluna Health, that's all we need to go to. Let's see, Aileen Armstrong is here to present.
Let's see. Good afternoon. Can you all hear me?
Yes, we can hear you.
Okay, my camera is not okay. Good afternoon, commissioners. My name is Aileen Armstrong, and I'm the Director for Maternal Child Adolescent Health Section. Our acronym is MCAH, and MCAH will contract with the program administrator, Haluna Health, for Sister Web to provide community doula services that are new and innovative for San Francisco, our perinatal population with the highest disparities. So we're targeting our Black African American population because they have had highest perinatal poor birth outcomes with infant mortality as well as preterm birth. And there's a budget amount of over 3.4 million through 2027. And the funds are with the new Board of Supervisor add back funds. And also we have additional funds from the state CDPH, California Department of Public Health, our perinatal equity funds. And we're hoping each year to target approximately 90 participants, which is 30% of the target population that we're trying to make improve their outcomes. Any questions? And this, we had an existing contract with Haluna Health due to the fact that Sister Web was a sole source provider, and it contracts have it where we have to now, we put it out for an RFP. Sister Web and Haluna Health were the one who were identified and met the requirements, and now we are going into a much longer term contract.
Commissioners, any questions or comments? There's no one on the public comment line still.
My comments, thank you, that you're gonna, say, you're saying that 90 participants would participate this, in what, each year? Is that, uh, that would be 90 different participants, so that's about 270 participants over a 3-year period?
90, well, we were thinking that if they can at least minimum target 30% of our Black African American births and people that have live birth. So we were looking at that we have approximately 300 birthing people who are delivering, and that we were talking about hoping that they can provide a doula for about at least 90. They have a program called Kindred, and the Kindred program is specifically targeting the Black African American. And also part of that budget, this new contract is to hire Kindred Black identified doulas to serve the population, target population. We're trying to make a difference in the outcome. So we have identified minimum that 3 to 4 doulas during the fiscal year.
And so is there any idea of how much, in terms of the cost for a doula for delivery, or is it per service that you're doing? Because this is just a huge block, it says. I mean, it's only by the month, so I'm just trying to find out, you've given me the capacity, but I'm not quite sure I understand. Do the doulas anticipate making 5 visits per member that enrolls into this? I mean, this is a great program. It's important. I just want to know fiscally how much this is going to be costing for, say, each member that we serve.
That's a great question, Commissioner. I'm going to ask if anyone from Palooza Health, our sister rep, can speak to Commissioner question.
I believe Ms. Armstead is here from the program.
Yes. I'm going to turn, I just wanted to say hello, I'm present. I'm going to stop my video because of bandwidth and let you know just about our program. So when doulas are working with our clients, we're talking about a course of care that lasts about 6 months from the assignment of the client to the doula to their last postpartum visit. They have 7 prenatal and postpartum combined scheduled visits. And they also attend the labor and delivery, which can last 10 hours or more. And they usually kind of work in a loose form of shift. In addition to that care, they also spend time with case management, resource care coordination, so community resources, connecting them to other things like our the family nurse partnership and the public field health nurses, trying to remember all the acronyms, as well as connections to places like Black Infant Health or Homeless Prenatal, places like 18 Reasons for groceries and food training, and Bayview Soul for grocery deliveries, in addition to other community resources that they may need, support in attending court cases, or maybe perhaps attending doctor's appointments as allowed with COVID health restrictions. Each hospital has a different policy, so we follow the hospital policy. So the doulas work full time, and at around the 37th week, most folks give birth at around 39 weeks to 40 weeks, but anywhere between 37 and 42 weeks, our doulas are on call for the mom that's about to give birth. So if she calls at 3 in the morning, if she calls at 4 in the afternoon, the doula has to be ready and available to answer the call and or go to the hospital. That includes false alarms, quote unquote false alarms, or when a client is sent back home, which happens quite often, especially during COVID. So it's not just like, you come into my office, I see you, you're gone. It's not like a doctor, patient provider experience. It's much more holistic and much more wraparound and encompassing. And so basically that's what the doula is paid to do, is to be there as a support person throughout that pregnant person's pregnancy experience, whether that ends in miscarriage. You know, some folks miscarry their babies, so they're a part of all of that experience. So that's pretty much what you're caring for, and we're in the process of really trying to quantify that and tease it out for folks like you all who really need to have a better understanding of what all we do. We know that in every hour of direct service, our doulas spend about an hour to an hour and a half preparing or creating or, you know, determining what resources are needed. That could be connecting with mentors and other, again, community partners like Team Lily at ZSFG or, you know, any of those things. So we do a lot of care coordination in the background. So it's not just the direct service, it's the navigation and case management in the background. And hopefully that answers your question.
Well, it's very helpful to understand the scope of the work, and the work is very important and could be quite helpful. You know, we've understood doulas are very useful in many especially underserved populations. So, and being that I'm sure you've written the RFP so that there is an ability to make sure that the work can be done and will be appropriate. So, thank you.
Any other questions or comments, commissioners? If not, this is a action item for a new contract.
I would move its recommendation onto the consent calendar for the commission.
And I will second that.
Thank you. And with the action of those two commissioners, the item is approved. Thank you so much. Very much for both of y'all who helped present and answer questions. We can move on to item 7, Baker Places Positive Resource Center update. Mr. Wagner will present. And commissioners and Mr. Wagner, I just want to check in. We have about a half hour before the meeting has to end. So I'll check in about 10 minutes before the meeting needs to end. Just want to make sure we have kind of a umbrella of time there. All right, go ahead, Mr. Wagner.
All right, can you hear me?
Yeah.
There, and we can see you too.
All right. Okay, great. Good afternoon, commissioners. Greg Wagner. Max Roca from the Behavioral Health System of Care is also here to discuss this item. I'll give there was a memo included in the packet. I'll give a quick summary of that, but really want to kind of leave this as an opportunity to hear your questions and ask you what information may be useful. I know there were some questions that already went in through Mark that we can talk through in response to the memo. But as you know, Baker Places, which is one of our behavioral health contractors, has been in financial difficulties. I would also say it extends beyond financial difficulties. They have significant administrative capacity issues that have been also hindering their ability to recover financially from the challenges that they have. Conversation has been going on for over a year with Baker. They approached DPH and the controller's office in 2021 concerned about reimbursement relative to their costs. We initiated our regular level of response to that. But in addition, we worked with the controller's office to hire a financial consultant at the city's expense to look at their underlying issues. And so we had been going through that process for some time, but it soon became apparent over the course of the spring that they had, although they had initially approached us about the fact that they did not believe that their contracts were sufficient to cover their operating costs, that the real issue was that they had accumulated a large cash deficit. They did not have enough cash to meet their operating needs, and that is in many respects a different type of issue. That kind of culminated in late May when the department went to the Board of Supervisors and requested an emergency grant, which the Board of Supervisors granted at $1.2 million with the purpose of simply providing the organization cash to meet their payroll to get them through to the new fiscal year when they would get their advance on the New Year's contracts. At that point, we thought we were in more of a stabilized position until just recently in late September when Baker informed us that despite kind of where we thought we had been, that they did not believe that they would have enough cash again due to using current year payments to pay off prior year debts and other obligations, and that they intended to close at least 4 programs that they're under contract with DPH to provide. So we have since that date been continuing to work furiously with Baker. We are, and Mr. Roca can give you more details on kind of where things are, but working to identify transition plans for those 4 programs and possibly beyond. We have been actively, I guess I would say, pushing Baker and PRC, its affiliate, to please work with us to give us a transition period so that we can have an orderly transition of programs that need to transfer and give ourselves time so that we can avoid any impacts on clients, staff, other DPH programs while we make that transition. So I would say that they are in a very serious situation right now. They have, in addition to the cash shortfall, which we've been working with them to address, and the memo outlines some pretty extensive lengths that we've gone to try to help with both their reimbursement and their cash issues. That the department, the controller's office, MoCD, we've taken steps that are significantly beyond what we would normally do through technical assistance, capacity building in most situations. But in addition to those, I think that there is a challenge, an administrative capacity challenge at Baker, including turnover in finance staff, including finance leadership. They are lacking in administrative capacity to really, in many respects, to be able to receive the financial help that we're trying to provide. So I know that you'll have questions, and so maybe I'll just leave it there for the moment. But we are in the process, and we've detailed in the memo, of transitioning 2 of those 4 programs to HealthRight 360, who we believe will be able to assume the contracts and the programs, and we'll be able to have a transition of ramping down admissions at the Baker programs and ramping up with HealthRight. And then Max and his team and Dr. Cunnins are very actively working on planning for the others. We're meeting with Baker literally daily to try to troubleshoot and problem solve and minimize any impacts of the transition that we're going through. So I'll leave it at that. If Max wants to add anything, please do. But I would be happy to have your questions and try to talk through it a little bit.
Yeah, good afternoon, commissioners. My name is Max Rocha, Director of Systems of Care at Behavioral Health Services. Augmenting what Mr. Wagner shared earlier, just to give a little bit more details on the 2 programs we're actively working on transferring to HealthRight 360. The 2 programs are Acceptance Plays and Joe Healy Detox. Acceptance Plays is a 12-bed facility residential treatment, whereas Joe Healy is a detox program. Both are slated to go to HealthRight 360. We do have a start date for Acceptance Plays, January 2023. And then for Joe Healy, we're still working with HealthRight 360 and Baker PRC to identify an end and start date. Part of the efforts is really about ensuring we safeguard the patient's treatments, course of treatment that they have in place currently, and make sure they finish the course of treatment The other efforts also include preserving the talents we have in San Francisco, the workforce. It's really hard to recruit staff. So HealthRight 360 is also working on reaching out to Baker PRC staff to extend employment opportunities to them, as well as the cities also to the city as well. So that's all the comments we have. I have, yeah.
I have a question, and I just want to say that, it's kind of disheartening to see, like an institution like Baker Places, it's yeah, and the challenges that they're facing right now, and being a former employee of Baker Places. So this is really near and dear to my heart. And I have questions because Baker Places own some of these properties where they have programs, such as Ferguson Place. It's donated to bakers, and what would happen to the ownership of these real estates when they close it down?
Commissioner, I'll just echo, yeah, I think we are all, share your sentiment about this. This is a sad moment for an institution that's been really important, to the city, to the public health department and our system of care. So this is a really hard, process. In terms of your question on the properties, I don't think it's yet known exactly what will happen. This is one of the things that we've been working on with Baker, and we have asked for help from the Controller's Office and MOHCD to advise us on options for both Baker, but also how the city could be involved. Certainly, there is there's something to be done here with the fact that Baker has these assets in the form of real estate, but they also have debt. And so that has gone into their thinking is how could they use those assets to try to address the underlying financial problems. We at DPH have been looking at two possibilities. One is whether particularly one of the Baker properties, the Joe Ruffin, where the Joe Ruffin program is housed, whether we, as the city, would be interested in buying that building. That would allow us to continue programming there and become an asset for the city and also provide some cash to Baker PRC. So we're exploring that. That includes a structural assessment and various building compliance evaluations that the city needs before making a determination about that. We're also working with Baker on whether there are opportunities such as, for example, if in situations where Baker has a leased site, would it make sense for the city to either short-term or longer-term take over that site and use it to try to maintain programming under some different type of structure. But I think that there probably is some piece of the longer-term solution where the buildings factor into the kind of the ultimate financial outcome of what happens with Baker and PRC. And we would like to the extent possible, ensure that those assets kind of remain a portion of our system of care. And so we're working on that. And the reality is also, though, that the timeline for those discussions, because as you know, the timeline for kind of these major real estate transactions is a little bit longer. There are complicating factors, including Baker's debt and the fact that some of those buildings are partially financed or underwritten by MOHCD. That makes those identifying the form that any type of solution in that area will take a little bit more time. And so we don't have a precise answer for you about exactly what's going to look, that could look like yet.
So I think that, you know, I share this concern that Baker Place for so many years has been a very important part of us. And part of this I'm somewhat concerned is as they became bigger and acquired more, we sort of have had this mega contract problem, I think, and this is certainly possibly one of those potentials. So before we get to that broader picture, I wanted to know if we thought then, I mean, Baker Place is talking about giving up 4 programs, but are they really talking about, as you were right now, actually going out of this business?
I think what I would say is we don't know exactly what's going to happen. I am confident that Baker will end up smaller and different than it is today. Is it possible that they will retain some portion of their current portfolio? Yes, but we don't know the answer, and we are literally, like I said, meeting with them daily. The department now monitors their cash projections with them. We're identifying staff, financial staff, to go over and assist Baker with kind of getting his mind around what its options are. So I would not be ready to say that they're going to totally get out of this business. I would not foreclose the possibility. But we do know that some of these programs, at least some of these programs, are going to transfer now, and that they will be a different organization at the end of this process. I'm confident in saying.
And some of them have different funding sources, don't they? Like the other 2 programs that I know, one on Grove and the other on Baker's, they are actually behavioral health beds. They're not necessarily, you know, like for those who are dual diagnosed or, you know, have just substance abuse as the primary diagnosis. So they get different kind of funding, you know, and these are the ones that relies heavily on general fund, you know, to keep afloat.
Oh,
I have a follow-up question for, I'm sorry.
no,
Sorry,
no,
Dr. Chen, go ahead.
Go ahead, Commissioner.
I just in light of the fact that they do have different funding sources, so is the department coordinating, I guess, the support and assistance that they're providing to Baker Places with the other funding sources, or are we the primary funder so that we have a sway on the kinds of decisions they're making about the closure or continuation of services? I'm just sort of wondering if we're the only or major player in providing some resolution to the situation here, and what impact that might have on any support we could provide if they're having to sort of please and resolve the situation with other funders or supporters.
We're not the only funder. MOHCD has contracts with Baker for, is it 2 of their programs, Max?
Yeah,
2.
correct. 2 key programs, Lean and House.
And are there other non-city and county funders that, you know, might make it even more complicated?
I can only speak to, they do have foundation funds, private donors.
Yeah, the bulk of their funding comes from the city and the Department of Public Health, somewhat supplemented by private fundraising.
Greg,
And to answer your question, Commissioner, we are coordinating. So in the department and with MOHCD, we are coordinating, and the controller's office is also actively involved. So we are really trying to take a citywide approach to this.
Greg, do you know the role of the Health Commission in terms of to help them get a sense of where they are placed? Are they just going to be reported to around this on actions EPH has taken, or will some of this require their vote, approval at some point, like the grand plan? I know this is all kind of being made up as we go along, but I think you have more of your hands on this than they would on their role in those decisions.
Yeah. So I think we don't have the exact answer. I would start by saying, right now, the Baker and PRC have made this decision. So we are, and we concluded that it is in the best interest of our clients and our system of care to find alternative providers, because we don't have confidence that the way that this has happened is there have been kind of these sudden changes in our understanding of their position. It feels very unstable, and we feel an obligation to find these alternatives so that we don't have that uncertainty. A couple of things, though, that I think the Health Commission may be involved in, and will certainly keep you updated. But there is, number one, the possibility that we will have to modify or enter into new contracts to transition those programs. There's the possibility that we will have to modify contracts with Baker and PRC as part of this process. So, for example, we in the past, in some circumstances, have, when we've exercised the termination provisions of a contract, modified the budget to include costs that are required for the transition. So those, as we go through those and we get to that phase where this becomes really more about the specifics of what we're proposing in terms of the contract transitions, those would likely come back to the Health Commission in some form or another. But on the kind of overall question of should this happen, I think that Baker has made that decision and notified us of their decision. So now it's for us to find an alternative means for providing these services within the department.
Mr. Wagner, did I add correctly that there's something like $11 million that as I just go through the numbers on your memo, that we've either given them in advance or that we granted them?
Yes, that's correct. And the of those amounts, the pieces that are, some of those have to do with how we are handling money that is owed to us by Baker. So within those, that memo you saw, for example, they had outstanding debt prior to last year due to some old Medi-Cal settlements where the audits turned up repayments that were required based on documentation, et cetera. And then in last year, last year we deferred their repayment of the advance that we make at the beginning of the year. We did that because there was simply no way that they would otherwise have cash to continue meeting payroll. And we made another initial payment, an advance payment, in the current year. So there definitely is, of the debt that the city or that Baker PRC carries, the city is the largest portion of that. They did use the advance payment that we made to them at the beginning of this fiscal year to pay off other debt, is our understanding, which significantly reduced their other debt. But we are probably about 75 to 80% of the debt is to the city in the form repayment of funds that were essentially loaned or advanced to Baker from the city.
So I have another question. Do they still provide like services to the city's master leasing programs?
Max?
Yeah, they do. So I think you're asking about Commissioner, Assisted Independent Living Program. That's one of
Is
them.
that what they are? Like, so like Windsor Hotel, Pacific Bay Inn, all those like, those are like city master leasing SROs, you know, like, and maybe it has changed since then, you know, that we provide integrated services to.
Yeah, they are not providers at those sites. Yeah.
Okay.
Yeah.
It's Mr. Wagner, is there something that we can learn from this to say that because we have other large contracts that there may be a different way of trying to monitor that our process might be more proactive for huge contracts or large, large deliverers of services like this that we could then offer earlier help or I just, it's kind of the idea of prevention now. And we know that, I mean, we're transitioning to Health Right 360, but then how do we prevent them from going through a similar cycle with good intention, but with, poor information, let's say?
Yeah, that's the well, I was going to say the $1 million question, but it's more than $1 million. But that really is excellent question. Don't think I have the kind of profound answer to it, but I'll give you some thoughts. And I expect that we'll continue to talk about this over time. I would say, so number one, we are kind of reevaluating in our process, what should we have done earlier to kind of understand the gravity of the situation. So DPH, as you all know from being on this committee, we have various monitoring and assistance tools that go into effect in certain situations. The controller's office has convened a process with the Department of Public Health, the HSH, DCYF, the departments that are the major funders of CBOs, to take a look at a whole bunch of different things in that regard in terms of our shared city policies. And those include things like do the cost of living adjustments keep pace with the actual cost of services? I heard you all talking earlier about indirect costs and how those are funded as part of the process. And then also, I think, just what is our monitoring processes and how do we make sure we're kind of finely tuned enough to know the difference of the types of situations that we encounter regularly, where usually we are able to step in and those tools work to correct what's going on, in a case like this where we're not. The other thing that I think I'll say that I don't think really have our minds around yet, but we are kind of soul searching about this. Number one, I think in this case, the situation was somewhat obscured by COVID. Because during COVID, when we saw a big drop of units of service, we changed the way that we reimbursed our vendors. And we just essentially said, we're going to pay you your full contract, even if you're not delivering the units. And so that kind of cost reimbursement, I think it hid, and the drop in units of service due to the COVID restrictions hid some of the things that were happening underneath the surface. But I would say most importantly, a lot of what happened here is in it occurred in areas that we don't see necessarily through our normal look at what are your costs, what are your units of service, are you making your units of service, delivering your units of service. A lot of this had to do with debt and cash flow. You know, one of the big red flags in retrospect that I think we probably need to kind of revisit what we could have done differently is Baker had not produced a financial statement for quite some time. And we had identified that and we knew that, and it appeared there was kind of a plausible explanation as to why. But in retrospect, I don't think I think we should have pushed further on that, because it was both a red flag about the organization's financial management capacity. But also, once we saw those financial statements, the data in there showed us that there was something to be worried about that we saw a year later than we otherwise would have. So I think that was an area where we kind of took an explanation for why that had occurred at face value. And had we not done that, we may have identified an issue sooner. But it also really is, I think in this case, a big question mark for me is, you know, we can provide financial support, technical support, but we can't manage the organization by the nature of our legal relationship. And in this case, I think there has been kind of administrative deterioration to the point where even when we can provide cash or funding, the agency is not in a position to receive it because of the kind of breakdown in administrative infrastructure. And that's a tricky one because it is a separate legal organization, and that's not something that we control. So those are my thoughts, and there'll be, I'm sure, a lot more to come. And we really are thinking about that exact question that you asked, Dr. Chow. How do we see this coming and avoid it earlier? Because you're right, if this was health right, we would be at a different scale of challenge.
Right. Well, I'm really appreciative of the thought that you're putting into it, because it seemed to me, and you had pointed that out already, if we had been receiving audited financial statements, then perhaps this might have shown up sooner. And sounds like you were taking their word for it. And, you know, we have trusted partners, but I think when we
Yeah.
fiscal issues, I think we didn't do them a favor by not, you know, being more helpful when perhaps this could have been turned around earlier.
Yeah, I'm curious, like at what point, I know that we are working closely with the controller's office, you know, in terms of providing technical support, but has the controller office offered to do a full audit for the organization?
The controller's office has provided a financial consultant to do a financial evaluation and a sustainability plan. The controller's office practically, and also I believe kind of legally, ethically, could not produce the organization's financial statements for it. They are like any organization required to have an independent auditor produce their financial statements, and since they are our contractor. But beyond that, and all of our contractors are required to produce timely and accurate financial statements, independent auditor. But so absent that, controller's office did hire at the city's expense this financial consulting firm that has been working with us and with Baker to do financial projections and also come up with options for how that have fed into some of our solutions that we propose to continue the cash to Baker.
You know, I think that, you know, cash flow issues aren't limited and certainly not unusual, particularly nonprofit organizations, and those are dependent on funding, especially if funding comes in arrears. But I think the debt issues probably, and I don't know to the extent, they were under debt, but I would imagine that, you know, uh, carrying debt, and then maybe not having a board that was as familiar with, the financial oversight, as they might have needed to be, and that's not an unusual situation, even in longstanding nonprofit organizations. So there are some of those things I think that go beyond just, management's capability, in terms of oversight. So it is a whole ecosystem that sort of has to come into play. And I hope that we take on a position where, we're not, and it appears so with Baker. We're not trying to be punitive. We're trying to be supportive, but I do think a proactive monitoring of, the necessary parts of the ecosystem that go hand in hand with programmatic oversight is something that, especially if it's an organization that is highly dependent on city and county government funding, it's really our responsibility to try and be as sort of supportive and open to the ability for our contractors and those who provide services on our behalf to be as open with us as they possibly can, so that we can support them. Because we can't afford this infrastructure in the community to fall apart. And so I really appreciate everything that the city and county is doing. And Greg, I really do appreciate, it seems like your very personal sense of, support and problem solving. So again, the more that we can know in order to support, I think the better. And then help to not let this particular situation get the narrative of what happened be something that makes it impossible or difficult for the city and and this department in particular to continue to support community-based providers as the need, will only continue to grow.
Yeah, thanks, Commissioner. We want to do everything we can to not ever get to this position.
And commissioners, with that, I want to note one thing that Commissioner Green urged me to share with you all, that she reviewed this carefully and looked at the 990 forms that agencies have to, I think they have to do that annually, Greg, and she saw that there were red flags from 2019. So something to note when you hear more updates, to maybe ask more about that. And Greg, maybe something for y'all to consider too as part of the monitoring. But we have to be out of time because we have to transition. I have to physically transition to the other room. So this is not the last discussion you all will have. We'll have other updates on this and it might come to the full commission next time. I think we're trying to bounce back and forth. Thank you, Mr. Wagner, very much. Let's move on to item 8, which is emerging issues. Anything from y'all commissioners? There's no one in the public comment line. And
I would just like to reinforce Dr. Chow's sort of request around, what a discussion, about, what are we going to do with organizations that are potentially too big to fail, and some sort of an agenda item around that, if possible, sooner versus later.
yes, thank you so much.
For some context, Commissioner Guillermo, this has been an ongoing question from us, from the commission, regarding, this whole too big to fail scenario, dating back to when I first took over as the chair of this committee. Yeah.
And they've gotten bigger.
Oh, all right. So commissioners, I'm sorry, we don't have a lot of time. So I've noted it, and we definitely will note that for possible for this committee and possibly for the full commission too, because it's a topic that relates to both. There's no public comment, and so we're at a consideration for adjournment.
I would so move.
Okay, thank you so much.
Second.
Great. So we take that as an action, and thank you so much for everyone who presented and spoke. And commissioners, I will see you in another room in a few minutes. Thank you.
Thank you.
Bye-bye.